Okay, good morning everyone, or good afternoon. I guess we're at noon, so we're kind of limbo. One or the other, morning, afternoon, on the fence. Okay, so we're going to be talking about myocardial perfusion imaging today and some of the basics in terms of how we set up imaging and perform imaging. So first of all, let's go into some of the radio tracers and different things about radio tracer admissions. So, you know, we have alpha particles, and I don't have a mouse, but that's okay. You can see it up there. The alpha particles, we really don't image because they're stopped by basically a tissue paper. Beta particles are stopped by a piece of paper, a plain old piece of paper, and only gamma rays can really get or penetrate through body tissues, and et cetera. So that's what we image in both single photon tomography as well as positron emission tomography, although we use different KVs for both of these kind of imaging techniques. And all these different radio tracers and radioactive emissions also have importance in terms of radiation exposure. So there's something called relative biologic effects, which is based on basically equivalent radiation dose. And that's based on the radiation emissions, such as, for instance, alpha particles, which have about 20 emissions for every, have a factor of 20 for every emission, which is very, very high. And that means there's 20 or more ionizations per every particle. And I think you probably remember many years ago, there was a Russian spy who actually died from alpha particle emission ingestion. And that was with polonium, the assassin's choice. And it really is because it's about 250,000 times as toxic as cyanide. So you can imagine it doesn't take much in terms of alpha emissions to really kill you. Thank God we don't image them. Okay, as far as beta and gamma particles go, they have a factor of 1. So actually the radiation exposure is relatively low as compared to the other, like alpha particles. And then we have the effective radiation dose, which takes into consideration tissue sensitivity. So obviously abdominal tissue is less, or neck tissue in the neck is less, muscle is less sensitive to radiation, brain is less sensitive to radiation than, let's say, ovaries and other reproductive organs. So then let's talk about what we do image. And what we do image are photoelectric effects, Compton scattering, and positron emissions. And so in single photon tomography, we actually, in SPECT imaging, we actually look at interactions in tissue, which is obviously the body, and we look at interactions within the crystal itself. And within the crystal itself, what we really want to see is what we call photoelectric effect, where we have 100% conversion of a photon into light energy. Okay, and that's what allows us to be able to see something and count something in a crystal. In tissue, we also can have photoelectric effect, or we can have electron absorption, okay, where nothing gets out of the body, or we can have a lot of times Compton scattering, where photons hit little pieces of tissue, but they don't lose all their energy, and they're scattered to another piece of tissue, and that can cause a lot of problems in terms of spatial resolution. And then we have, with PET imaging, we have positron emissions, where obviously with all of our PET agents, we emit positrons, which are basically positive electrons, and those interact with negative electrons and cause annihilation, which then results in a very high energy 511 keV photon, which is obviously much higher than what we use in SPECT imaging, which is 140 keV, such as technetium. Okay, and so in PET imaging, as I say, we get these annihilations of 511 keV, and they go 180 degrees in opposite directions, and we image them with a different type of gamma camera. But the bottom line is that we also are interested in the energy of the individual agents we use. For instance, fluorine, F18 has a 0.635 MeV energy to it, whereas rubidium 82 has 3.35 MeV. So rubidium puts out extremely high energy photons. And what does that mean? It basically means that the spatial resolution of F-18 is actually much better because you have annihilation occurring closer to where the photon was emitted as compared to traveling further, which will happen with the rubidium photon. So that gets into the whole issue of spatial resolution, and we'll talk more about that. Okay, the other thing we don't image are charged particles, and I said already that alpha particles we don't image, and beta particles, which are really either electrons or positrons, we don't image. But there are certain interactions that happen in tissue with both of these kind of particles, and these particles can interact with other electrons, which is called excitation. You can have ionization energy, where a photon comes in and drops out and kicks out an inner shell electron, and then an outer shell electron falls down, and that's called ionization energy or characteristic X-rays. And you can also have these things called Bremsstrahlung, which are breaking X-rays, where you have an electron go around the nucleus and it slows down. And when something slows down, when it loses kinetic energy, then it has to give off other kinds of energy, electromagnetic energy, right? And that is what we actually see, not in SPECT imaging or PET imaging, but actually in CT. That's the whole basis behind CT, is looking at characteristic X-rays and also breaking X-rays, is Bremsstrahlung. So different techniques use different ways of looking at and using radioactive or radiation to acquire images. Okay, so let's talk a little bit of photoelectric effect. That's basically when a photon is absorbed by an atom. So obviously very high density materials such as lead, for instance, will absorb most, if not all, photons if they're at least a certain energy. And in the crystal, at 140 keV, most of those technetium photons are going to be absorbed by the crystal. And that's going to be a photoelectric effect. And that's what we really want in order to see imaging occur and see a picture. The other thing that can happen, I already talked to you about a little bit, is Compton scattering. Compton scattering is a real problem, particularly with low energy photons, such as with thallium, which was a 72 keV photon, as compared to, let's say, technetium, which is 140 keV. So higher keV photons have less Compton scattering. Low keV photons have higher degrees of Compton scattering. And the interesting thing about Compton scattering is that the greater the degree of the angle, the greater the energy loss, but it's also specific to the type of energy that you're dealing with originally. So low energy photons, for any degree of angulation, lose less energy than high energy photons, okay? And that actually leads to additional problems, because that means that with thallium, you could actually have a 78 degree scatter of a photon, and because it still hasn't lost enough energy, it will be counted in the camera image detection system. So that's a real problem, whereas with technetium it's down to 54 degrees, and with very high energy photons like F-18 it's down to 27 degrees. So where they're eliminated because they've lost too much energy. So it's important to keep in mind the issue of Compton scattering, and also the type of radiopharmaceutical you're using and the intrinsic energy of the radiopharmaceutical. And the other thing about Compton scattering, it's not just one scatter, you can have multiple scatters. And with every scatter you have a different loss in energy, a cumulative loss in energy. But this can cause a lot of degradation in terms of image quality if these kind of photons are acquired. So in a typical gamma camera, you have the source, you have a lead collimator that sits on top of the crystal, then you have the crystal, then you have light detectors, and all of that light is then acquired and defined in terms of its locale, and an image is created. And again, that's with light. So with single photon tomography, with positron emission tomography, we have what we call emission data, right? So what happens is a radio tracer is put in the body, it's emitted, and then this is detected by the camera system. And again, the most important thing with these emission type studies is you acquire enough photons to really have an adequate quality image. So the number of photons is critical to the image quality that you get, okay? And so just to keep in mind, when we think about generating images, energy, or kV, is like the locomotive. I always think of it as the locomotive. It's what gets you there. It's what gets you to the tissue, okay? But the photon flux, or the amount of photons that are emitted, really make the image. So the photons kind of sit in the train, and they're carried by the kV to where they need to go, but it's the photons in the train when they get there that really make the image, okay? So it's really important to have counts or photons in order to be able to make a good image. And that's the same thing with CT. CT and actually nuclear imaging are very similar, except that CT is a transmission scan, whereas nuclear imaging is a emission scan, okay? And with CT, obviously, again, it's based on the issue of kV and photons. So if you have a very large person, 140, 50 BMI, you're going to need higher kV in order to get photons to where they need to be. But by the same token, the image quality is going to be determined by what we call the MA, which is basically the amount of information carried by the high energy keV photon. Okay, so if you look at the probability of events in tissue and in lead and in crystals, you can see that with all of our traces, whether they be 511 kV or whether they be 140 kV, or in blue, whether they be thallium, you can see that most of the interactions in the crystal occur as photoelectric effects over all of those different tracers or energies. Lead, of course, is always photoelectric effect, because very few things get through lead. So they're absorbed and you have a photoelectric effect. In soft tissue, however, most of everything is Compton scattering, okay? The higher the energy of the photon, the less the degree of interaction with tissue, but still, Compton scattering remains a real problem in terms of soft tissue. And of course, photon attenuation is determined by many things. It's determined by photon energy, like I just said. It's determined by the material density, such as lead, which doesn't let much of anything through, and it's all absorbed, and you get photoelectric effect, or the material thickness. Okay, so the thicker the material, even if it's low density, if it becomes very thick, you're not going to get photons through. It's going to be stopped. Okay? All right. So let's talk a little bit about collimators, which are the first things that really hit, the photons really hit, okay? So collimators are designed to limit the detection of gamma rays that are traveling in bad directions. Okay, we really want particles coming from an X-ray source to be able to go through the collimator and hit the crystal. But those that are coming from different directions, we want them to be stopped. And these collimators are basically lead septi. Okay, so they're made of lead, so they're going to stop photons that are going in the bad direction, from getting into the crystal. And I often think about it, if you remember the old Star Wars movies, I mean, they had to get that little bomb down into the hole to blow up the Death Star. Well, it's the same thing. I mean, if it hits the wall of the Death Star, it's not going to do anything. It's not going to get in. If it hits the other side of the Death Star tunnel, it's not going to do anything. It has to go right down the hole to be identified. And that's the same thing here. I mean, things that hit the lead septi are not going to go anywhere. But thank God they're not, because they're not going to give a good image. You want those that will go straight down and hit that crystal. Okay, so let's talk a little bit about resolution. There's these things called full width half maximum and 10th width half maximum. And what you do is you look at the peak in terms of the peak value of a given photon. And then you take half of that, and that's your 50%, that's your half maximum. And if you take 90%, that's your 10th maximum, okay? And that determines our resolution. So let's look at this point spread function. And you have two points here, okay, in space. So you have maybe a circle and a circle, okay? And the question is, can you detect each one independently? Well, that's going to be determined by your full width half maximum. So you'll notice that that yellow bar is the full width half maximum of those 2 points. And since those 2 points are further enough away from the full width half maximum, each one will be detected individually, okay? But take this for instance, here's another peak, and now we have this. And you'll notice here now that the 2 peaks overlap the full width half maximum. So this will be looked at, and when you image this particular object, maybe like 2 coins or 2 points in space, you will not be able to determine that there are 2 points. It will look just like 1 point instead of 2. Okay? And so that's the whole concept of spatial resolution, being able to resolve different points or different tissues accurately and not just see a blob and you know, because your resolution is poor. Okay? Okay, so collimator resolution is determined by several different things. It's determined by the diameter of the holes, of the septi holes, and the length of those septi. And the sensitivity is the inverse. The sensitivity is how many counts actually reach the crystal. So they're inversely related. If you have wide bore holes and you have very short septi, then everything's going to flood through. Okay, and you're going to have very high sensitivity, but your resolution is going to be terrible. Whereas on the other hand, if you have extremely long septi and you have very narrow septi, very few counts are going to get through, but the ones that get through are good. Okay, so sensitivity is inversely related to resolution. So this is exactly a diagram looking at this. As you increase hole diameter, you decrease resolution, you increase sensitivity, etc. If you increase the length, you increase resolution, but you decrease sensitivity. And the other one important point about imaging people is that it's also important how far the detector is from the patient. So when you bring the detector closer into the patient, you actually don't image more counts. But what you do is you improve your spatial resolution. And that's why, you know, whenever we try to image patients, we put the camera as close to the body as possible. And that's why if you look at deep structures in the heart, such as like the inferior and posterior walls, you have less resolution looking at those walls than you do, for instance, the lateral wall of the heart, which is closer to the surface, or the anterior wall, which is closer to the surface. And there's actually some algorithms we use called resolution recovery to actually take into consideration. They're mathematical models to try to improve resolution of those deeper structures. But it's very important, since we can't do much about it, I mean, we can't literally put a camera on the inferior wall of the heart, but we can certainly put the camera as close as possible to the chest wall of the patient to get better image resolution. This is also the situation looking at different types of collimators and looking at sensitivity and resolution. And you can see that as they're inversely related, basically. And the very high energy or the very high resolution collimators have very low sensitivity. But look at the spatial resolution. It's actually great. Okay. Whereas high sensitivity collimators, which have very wide bores and very short septi, you'll acquire a lot of counts, but unfortunately the resolution will be quite bad. Okay, another issue, or looking again at this issue of distance from the collimator. So on the top diagram, you'll see a point spread function again, and you'll see what a typical image or the point spread function might look for a typical photon being imaged with a relatively low energy collimator. Now, if you look in the middle, look at what happens when you take that same collimator, but you move the source further away from the point source, okay, from the collimator. And look how wide that point spread function now becomes. Now, if you go to a high resolution collimator, but keep the point source in the same point, very distant from the collimator, now look how narrow the point spread function becomes. Okay? So by changing the collimators or by changing the position of the patient, you can improve or lessen your resolution very, considerably. So again, the further you're away, the more you reduce resolution, but that can be somewhat compensated by using a very high resolution collimator. So again, once again, collimation is critical in terms of keeping the patient very close to the collimator surface. And this looks at this again. Remember that when X-rays come out, they come like a sunburst. They all go in different directions, like the sun with its rays, okay? And so the further out you go, the more the less the resolution, because you accept more photons that are not in the, being emitted from the point source. Okay, now let's talk about the detectors themselves. So we have sodium iodide crystals. That has been like the mainstay of SPECT imaging over the years. Light detector, we have a voltage discriminator. The voltage discriminator is very important because let's say a photon goes through that only has energy of 100 keV because it's been Compton scattered or whatever. We have a certain criteria where photons have to meet a certain energy before they'll be accepted into the image. So they may get through, but this is like now another safety gap in terms of being able to determine whether something will be actually imaged or not. So the other thing is crystal thickness. So obviously the thicker the crystal, the more photons you're going to accept. The thinner the crystal, the more photons that are going to go through the crystal. So you have to have sort of a happy medium between thick and thinness. And it also depends on the type of radio tracer you're using. So if you have a high energy radio tracer, either you have to use a different material or you have to have a thicker crystal as compared to a lower energy radio tracer. So this is our voltage discriminator, and basically you can look at this. There are many photons that have been acquired or gotten through the collimator, and now the voltage discriminator is trying to decide which one should we really accept. So let's say this is technesium, okay? So it's going to be 140 keV plus or minus 10% on either side of the 140 keV for a 20% window that will actually accept. So you can see some of those photons are going to be accepted, and some of them, even though they got through to the crystal and cause the scintillation, will not be accepted because they're not the proper energy. So this is now a secondary measure to help prevent obtaining or acquiring inappropriate photons. But again, the problem with this is that you then again further limit the number of photons that you're acquiring, which, remember, will affect image quality. So then in those kind of situations, obviously it's very important to image either with a higher number of millicuries that you give the patient or for a longer time period so you can acquire enough counts. This is the spectrum of what you typically see, and you can see the very high one is what you would want when you're imaging. You're going to accept those 140 keV photons given a certain window, and all the other ones you're not going to accept. And there are a lot of different photons that actually, are generated when you give a radio tracer to a patient. You have the photopeak ones, which are the good ones, the ones that are 140 keV that get through. You have backscatter peak photons where a photon may be in the patient, go backwards and then come forward again, not lose any energy and still sit within that photopeak. You have lead X-rays where a photon hits lead and isn't totally absorbed and probably will not be detected by the detector or go through because it's lower energy. And then you have all these Compton scatters. Remember, you don't only have just one Compton scatter, you can have 2, 3, and 4 Compton scatters with a given photon. So those can all be identified in terms of the pulse, in terms of the spectrum, and eliminated. And so here you go, you have your typical spectrum components. The photopeak is what you really want, the 140 keV, and all the other ones you're hopefully going to be able to eliminate based on their energy in the pulse height analyzer, since they haven't met that specific window for acquisition. Okay, so SPECT has also developed over the years in terms of the types of crystals we use and the types of detectors. And nowadays, we still have, sodium iodide detectors, but cesium and CZT detectors are becoming more commonplace. In fact, we're about to buy another CZT detector for our laboratory, a spectrum dynamics one within this next coming year. And the reason why these detectors are better is because they reduce imaging time, they reduce the need for radio tracer, in terms of the radiation exposure, they improve spatial resolution, and they improve energy resolution. And remember, energy resolution is being able to look at that one little area of energy in terms of whether that's a real photon we want to keep or not. And the other thing about CZT cameras and these new technologies is that they can be done without collimators, and that you basically directly transpose or create currents based on the electron flux. So CZT detectors have very good energy resolution. It's less than 5%, which is really good. And they obviously don't need PM2s, photomultiplier tubes, as a way of analyzing data. So from that particular point of view, they're much better. This is just looking at a typical energy resolution curve, and you can see with thallium, with the sodium iodide crystal, you have about a 10% sway in energy resolution, whereas with CZT it's like 4.5, which is really, really good in terms of being able to detect proper photons. Okay, so now we've got an image. Hopefully, we've acquired the right photons through all of this. And the question is now, how do we actually make an image? Well, we look at three-dimension. We have a three-dimensional way of doing things, right? And so everything is done using triangulation, or what we call back projection. In fact, back projection is used in multiple imaging techniques. It's obviously used in CT as well, as a way of creating a three-dimensional object. And the whole concept of this is that if you look at something from one angle, you have different information than when you look at something from another angle. And by combining all that together, you can form a three-dimensional figure. So just imagine that you just have one beam of light going through. Well, there's not much you can really tell about that. But then you have two. Well, now you have a little bit more information in terms of what might be there. Now you have 4 different angulations, and you're starting to see where all of those come together. And then 8 views. And you can see how you can create an image then by looking at where all of these different angulations add together to form a three-dimensional construct, okay? And so in SPECT imaging, we have 64 images basically we take around the heart. And with those 64 images, they're all back projected onto a grid just like this to get an accurate representation of the three-dimensional heart. Okay. Now let's talk a little bit about filtering, because filtering, now you got your image. Now you got to make it so it's pleasing to the eye, so you can actually see something or not see something. Okay. And that gets back into the issue of what kind of frequencies you use, and remembering that high frequency data is like, it's like if I were to go on the edge of this podium and then fall off the edge. That would be a high frequency event. Whereas a flat piece of paper would be a low frequency event, right? So the high frequency events usually have most of the information, have really good information. And in fact, that's also true with if you think about acoustics, with hearing and such, it's the high frequencies that really give clarity to things as compared to the low frequencies, right? So you want to have enough high frequencies to make a good image, but you want enough low frequencies to keep a baseline image there that you can look at. So let's just look at this. This is just a picture. This is an original image here. Now we're going to start removing the high frequencies. So as you see, as we continue to remove all of the high frequencies and only have low frequencies, now you have no image, right? So again, it's the importance of being able to identify and have a certain amount of high frequencies to have a balance, to be able to create a pleasing image that you can read. It's also an issue in terms of not only the filtering, but the number of pixels you have. So if you're looking at a computer screen which has a limited number of pixels, you're going to get a very blurry type of image. And you can see, as in this image, if you look at the bottom left versus the bottom right, the one on the left is much more high definition because there's a higher number of pixels. There's more information in every little part of that picture as compared to the larger pixels which give a very blurry image. So that's the other aspect of this that's very important. So when you think about how much to filter, and there have been, people have spent years determining, with different types of filters, different frequencies, what's the cutoff should be. We have to remember that all filters remove information because they remove high frequencies, okay? So the optimal filter is going to be somewhat subjective. You want to reduce noise, which is really high frequency stuff, but you want to preserve resolution, which is also high frequency. So it's going to be a balance in terms of what you do. So here's an example of an image where you have loss of high frequencies as you go across. And you can see that the first unfiltered image is very noisy. It's very granular. It's very uneven. And as you apply more and more filtering to it and take out the high frequencies, it becomes smoother. But you also don't want something extreme like on the right-hand side, because you might obscure a perfusion defect because you basically filtered it out, especially if it was a small defect, okay? So again, it's going to be a little bit of balance in terms of what you utilize. The other concept is noise. Noise is always an issue in all techniques, whether it be CT or whether it be nuclear imaging, or all of our techniques have noise. And in the SPECT world and in the CT world, it's really going to depend a lot in terms of noise reduction based on how many photons you actually accept. Okay? So there's a simple equation. Basically, the noise is 1 over the square root of the total number of counts or particles that you might have. So if you have, if you have an average 100 counts per pixel, the square root of that's going to be 10%. You're going to have 10% noise. Okay? But if you have 10,000 counts per pixel, now the square root of that, you're going to have only 1% noise, okay? So it shows you that when we do nuclear imaging, it's not only important that we give enough millicuries to get a picture, to get an acquisition, but we also have to determine how long we should acquire each separate image in order to get enough counts to be able to get a high quality, non-noisy image, so we don't have to over-filter, right? Because over-filtering, as I've said, just filters out not only the good things, but also the things that you'd like to see, such as perfusion abnormalities. Okay, so higher energy photons tend to pass through material, but they have less Compton scatter. We already talked about that, like the 140 keV of technetium versus the 72 keV of thallium. But the most important thing about photons and about keV is that the higher the keV, the better the energy resolution. And if you couple acquiring enough information in terms of counts, you'll get a high quality image with very minimal noise, where you don't have to do a lot of extra processing that can potentially lose information in your image. Okay? So the other thing that's important in typical SPEC systems, and in fact all systems, is the issue of the uniformity of the material that's being imaged, that the crystal, for instance. And there are certain things we look at. We look at gamma camera uniformity, spatial resolution, and center rotation as quality assurance means in our daily work. So uniformity refers to basically the similarity between all photons that are acquired across the face of a crystal. Okay? And non-uniformity obviously describes the differences that are seen across the face of a crystal. And there's something called integral uniformity and there's differential uniformity. Now, integral uniformity looks at uniformity across the entire surface of the crystal. And it can either be what we call a usual field of view, which basically is the whole crystal, or it can be a central field of view. And we look at different where we're not really looking at the periphery of the crystal, more just the central area of the crystal. And we do that by looking at basically a percentage of differences between different points on the crystal. So in integral uniformity, we basically look at different points, and we take the highest point, the highest count number versus the lowest, and in a different area of the crystal, and get a percent. So, for instance, the integral uniformity of this crystal is 9.9%, which is not very good. The differential uniformity looks at uniformity across adjacent areas of the crystal in both the x and y axis, unlike the integral, which is can be across the whole face of the crystal. And what we'd like to see is less than 5-6% differences as we look across. So if you look at this particular crystal on the top, you can see the integral uniformity is 5.6%, and the central field of view is actually really nice. I mean, if you look at the central part, which is the red triangle, if you look at the central part of the crystal, there's only 4.7% difference across that crystal face, and only 5.6% across the entire face. That's pretty good. Look at the one on the bottom. I mean, even if you have an untrained eye, I mean, you can see that there's a lot of variability in terms of the brightness and the darkness of that crystal. And you're talking about 10% and 12%, differences in uniformity, which would really degrade your image quality when you went to create your image. Okay, the other thing you have to keep in mind is that when we measure uniformity, we do it with the collimator on and with the collimator off. Okay, so intrinsic measurements are without the collimator. Extrinsic measurements are with the collimator. And what we would hope to see is that so the extrinsic measurements basically look at the resolution of the entire system in total. And one would hope that, with the collimator on, you would get even better resolution because you've already prevented a lot of that of those not uniform photons getting through to the camera face to begin with, which would cause blotchiness in terms of the flood. Okay, so causes of non-uniformity are multiple. You can have crystal damage, you could have PM tube failure, which actually is not the case with CZT cameras because they don't use PM tubes anymore. You can have improper coupling of the PM tube to the crystal, incorrect application of correction maps, which you have to apply every day to your system. And you can have problems with energy windows, etc. So you have to look at all of these things when you look at your floods or you look at the uniformity across the crystal as a potential reason why you're having poor uniformity on the screen. Okay, so that's gamma camera uniformity. Spatial resolution is looking at the ability to discern points in space based on the output of the electronics you're using. And so what we do here, we use bars. And we basically take these bars and we image them to see what we can discern the difference between two bars. So think about it as a point spread function. We looked at a point spread function. We said, can we differentiate this point A from point B? When we look at bars on top of that and we image bars, we look at what we can discern because each of these different bars have different differences between them in terms of distance, okay? So that's how we determine the spatial resolution. And then the center of rotation, remember these gamma cameras go around the patient. Even the fixed ones are rotating to take pictures in order to get a three-dimensional view of the patient. And so we have to make sure that our center of rotation is correct so that one point is not too far from another point in terms of the acquisition, because obviously over time, over space, if it's not in the same position across the 180 degrees that we acquire, then it's going to cause differences in image quality. So here's an example of what you see with rotation errors. The middle one is optimal. Okay, that's no rotation error. But the one on the left is just minus 1.5 pixels off, and you can see that there's a little bit of what we call an apical septal abnormality. And if you look at plus 1.5 on the right, you can see even a more distinct abnormality. Now, if you were looking at this and didn't realize that your center of rotation was off, you would say there's a apical lateral perfusion defect, which is totally not the case, right? It's just artifact. Okay. Now we've acquired all this information, okay? And we're going to look at these images and we're going to say, do I know how to read an image or don't I? Or can I read an image or can't I, okay? So we look for certain things. We look for motion artifacts. We look for evidence of subdiaphragmatic count activity. We look for attenuation, potential attenuation patterns. When we look at raw data to be able to determine whether they are influencing the pictures we're taking. Okay. So this is just an example of a patient with motion and where motion was corrected. And you can see on the top, there's actually an anterior perfusion defect, which when you then correct for motion, it's completely gone. Now, I am not a fan of motion correction. I really believe when you image somebody, you should image a high quality study and not have to sit and try to correct it, because no algorithm is perfect, okay? So whenever we do imaging, whether it be PET imaging or SPECT imaging or CT imaging, we always like to have motionless images, because motion correction is not always accurate. But this is just an example where a patient did have motion correction, and it actually did do a good job in terms of looking at the difference. This is another example of motion artifact.
How can you tell? Show me.
Okay, you can tell by looking at the raw data. So if you look at the spin data, that before you ever look at a study, you should always look at the raw data first to make sure that you can look at attenuation, potential attenuation artifacts, motion artifacts, etc. Okay? And I mean, if someone has motion, they should be repeated. I mean, if they're moving around and they're dancing on the camera, then they should have the study done over. You shouldn't say, oh, gee whiz, I'm just going to use motion correction software. Okay? That's just not adequate. All right? All right, this is another example. Now, here you'll notice on the top bar that there's actually a perfusion defect on the septal half and also on the lateral half of that short axis image. And in this case, the patient had what they call x-axis motion. So you have y-axis motion where the patient is kind of dancing up and down this way. And then you can also have x-axis motion where the patient is kind of moving or twisting around this way, okay? And if you look at the second acquisition, which we did this patient over. Now you see that perfusion abnormality is totally resolved. So it's important to look at the raw data to be able to see that. Another issue is breast attenuation, okay? So that's usually anterior lateral in terms of location, but I can tell you, depending on where the breast is in any given female, you can have inferior defects, you can have lateral defects, you can have septal defects, you can have all kinds of defects. It's important when we do our imaging in women that we actually image them the same way when we do stress and rest imaging. Because if you image differently, you'll get different results. So this is an example of a patient with a variable positioning of the breasts during imaging. So on the top scan, you'll see that the anterior wall looks very hypoperfused. But on the bottom scan, on the rest study, it looks totally normal. So if you look at this, you say, my goodness, the patient has LED stenosis, high-grade lesion, big perfusion defect. But if you look at on the right side there, you can see the raw data, and you can see that the breast positioning was very different on the first study as compared to the second study, okay? So this is an example of just, poor imaging. And this is another example of the same thing. This is a patient who actually came in with an acute chest pain several years ago from our lab, had an anterior defect that filled in, and normal ejection fraction, went for CT finally and had completely normal coronaries, and it was all just breast positioning. So, again, you need to look at the raw data and make sure. The other thing is diaphragmatic attenuation, which can happen, we always say males, but frankly, males, females, the diaphragm can always get in the way. Obese patients, also another where the belly is kind of pushing the diaphragm up into the chest. All of these things can cause inferior perfusion defects, and they can be problematic. Now, nowadays, we do have ways to get around these things. So, for instance, we do supine imaging, and then we do prone imaging. And prone imaging has become a really excellent way of eliminating both breast attenuation artifacts as well as diaphragmatic attenuation artifacts. And so if you image someone supine, and then you put them on their belly, and you image them prone, and the defect goes away, or it shifts. Doesn't have to necessarily go away, but it shifts. That's an artifact because real defects don't change with position, okay? The other thing is that more and more gamma cameras are now being equipped with CT. Now, in PET imaging, we routinely do CT on all images. With SPECT imaging, more and more we're using CT correction. And that obviously has helped a lot in terms of our ability to get accurate imaging. And then the last thing I'm just going to say is that the other important thing is adjacent subdiaphragmatic count activity. And when you have something like this, you really need to re-image the patient. I mean, we give them water, we try to flush out the gut activity. You can see this both actually with PET imaging as well with SPECT imaging. The SPECT imaging, it's basically the liver dumping tracer into the upper abdomen. With PET imaging, the stomach can actually end up having rubidium in the stomach, and you end up with a hot activity. But increased activity like this either can obscure a defect, or create a defect, or make the scan uninterpretable. And so, we try to do other kinds of filtering to try to get around some of those things. And one thing we do now is we do iterative reconstruction, which helps eliminate some of these. But again, if someone has high diaphragmatic attenuation, we really need to just re-image the patient. So, the other thing I was going to talk about today, which I'm not going to talk about because we're a lack of time, but the next thing we will be talking about on further lectures is then how do you really stress people? What kind of stressors do you use? What are the implications of the tracers you use with the kind of stressor agents you apply to them. Because one thing I want to stress also about all of these agents, beyond just the imaging itself, is that all of these agents have different extraction fractions, and that, you know, what you really want is an agent that increases extraction according to flow. And so, for instance, if you look at this, O15 water has linear extraction across all blood flows. But if you look at all of our other tracers, look at rubidium. Rubidium has rollover at higher flows. Thallium has rollover. They all have rollover. Especially the technetium agents like sestamibi and tetraphosphamine, they all have rollover at high flows, and that can actually limit your ability to detect perfusion defects. So on our next encounter, we'll talk more about this and other aspects of exercise and which tracers you should use and some of the clinical applications of what we do. But are there any questions about what I've talked about today? All crystal clear, like the crystals we use?
John, obviously you have to know what you're doing, because I could see so many areas of interference with your accuracy of interpretation. From a practical point of view, I have two questions for you. One, what is the resolution, spatial resolution of a SPECT study? Or
It's about 9 millimeters.
9 millimeters?
Yeah, and SPECT, PET is better. PET's about 6, 7.
Okay, you may want to use the microphone.
Oh.
And the other question to you is, obviously you do flow studies using PET. And I can see that all over here and what's the effect then on measuring flow? Okay.
So that is really an excellent question. So, you know, flow measurements are extremely helpful. With PET, remember when we look at a PET study on the screen, that's a relative blood flow picture. And then we apply algorithms to look at absolute blood flow in different areas of the heart. Okay? And so there are examples, for instance, where patients can have a normal looking perfusion scan and have reduced flow in multiple different areas. And in patients like that, particularly if they have abnormalities in ejection fraction at peak stress, you know, we worry about multivessel coronary artery disease. I can tell you that balanced ischemia, even in the SPECT literature, is maybe about, I don't know, 3%, 4% of patients that actually have true balanced ischemia, where you've missed them because they have no perfusion yet. And I'm talking about people that have normal studies. So flow is very helpful, but you have to be careful with flow too, because many things can affect microvascular flow. And so you can have normal epicardial arteries and have reduced flow in various parts of the arterial bed that is not representative of what we consider coronary artery disease. So whenever we read a study, like a PET study, I got a new phone. I turn. Whenever we read PET studies, we not only look at the ejection fractions, the wall motion, the flow, but importantly also the CT in terms of calcium scores to help integrate all of that to get a better picture of what the scan really represents. Now, SPECT may not be all that different, because with the new CZT cameras, and in fact the one that we're probably going to get this year, the count rates are high enough to actually measure myocardial blood flow. And that will be very intriguing. I mean, there's some preliminary work on using SPECT imaging with certain gamma cameras to actually look at absolute myocardial blood flow like we do with PET imaging. And there's been some concern about, well, you have rollover with at high flows, but remember, with rubidium, you also have rollover with high flow. So it's not going to be all that much different. So we'll just wait and see on that. Yes?
When we do CT
Speak up.
When we do CT attenuation correction, and it helps with seeing.
Use the microphone.
When we do CT correction, yes?
So
I had the same problem.
hello.
Okay, so when we do the CT attenuation correction, and it takes care of a diaphragmatic defect, of an inferior defect, but the prone imaging doesn't show that. How do you explain discrepancies usually seen between like prone imaging and CT
Okay,
attenuation
so
correction?
you know, we do in the spec lab, we have a CT spec camera, so we do CT correction and we do prone imaging on almost all patients that have any kind of abnormalities. And again, it becomes a little bit of a clinical decision, right? So there are times when you do prone imaging that the defect will go away completely, and yet on CT it may not completely change. And some of that has to do a little bit with co-registration in terms of how well the image was the CT imaging was co-registered to the actual nuclear image, right? The other thing that's interesting about CT correction in general is that the apex almost always shows reduced count activity as compared to the rest of the heart. And so for years we thought, why is this that, you know, the apex, that CT correction never corrects for the apex? And it's actually very simple. Because remember, when we're imaging the heart, it's a dynamic image. And it has to do with the fact that if we image just systole, there would be no perfusion defect. But when you look at diastole, the apex is always a little less than the rest of the heart in diastole. And when we think about our imaging, remember, you spend most of your time in diastole and only a short percentage of your time in systole. And when you put all those images together, all those gated images together to form a static image, you are left with a partial volume effect, and that's that apical abnormality. So actually, it's not that CT has failed, it's actually CT is very accurate, but you will always see a mild reduction in the apex.
All right, thank you.
Good, John, thank you very much.
Okay.